I worked at United Healthcare from 2011 to 2020. It was October 3rd was my start date, and I left somewhere in February of 2020. So 8 years. But I say after nearly 9 years of employment, I had to leave. The way they treat their staff was just too much for me. I had been moving from position to position for nearly a decade, only for them to force me to go back to taking calls I was taking when I first started, effectively erasing any progress I had made at the company in those I say 9 plus years, 8 plus years. This is my personal grievance with the company and not the reason why I'm writing this letter. I'm writing this letter to really highlight private health care in the United States from my anecdotal experience working for the largest private health insurer in the world. Now, of course, technically CVS is the highest at this point, but for some reason, United Healthcare always keeps calling themselves the largest provider of healthcare, but it actually is CVS apparently. Who knows? So let's see here. In this document, I'll go into what I was taught about the Patient Protection Affordable Care Act, how the largest insurer has no plans for the cliff edge this industry is pushing us to, how UHC secures over or screws over its patients, how the healthcare industry cheats people out of money, and yeah, a couple of weird conspiracies. One of those conspiracies never really came to fruition, and the other is still ongoing from what I can tell on the outside. Since there's a lot to go over, I will essentially follow a timeline. Now, yeah, so my first day at UHC was October 3rd, 2011. And we started United Healthcare as a provider phone representative, PPR. You have about 12 weeks of training. Most of those weeks are spent on the phone, applying what little you have been taught about the company. Essentially, they just make sure that you can read and then tell you to constantly pull up their standard operating procedures to figure out how it all applies. That's a little reductive, but essentially that's kind of how it worked. Early in training, we got a history of the United Healthcare. Most of it was dry and uninteresting, but one thing surprised me. This was 2011, and the Patient Protection Affordable Care Act was being challenged, specifically the mandate. United Healthcare wanted to teach us their stance on the Patient Protection Affordable Care Act rather quickly, and they did so by teaching us where the ACA came from. Per UHC training, in the early 90s, in response to the push for a universal health care program, United Health Group, parent company United Healthcare, board members wrote a counter program. One of the board members left UHG and joined the Heritage Foundation, where the document was finalized and shared as a counter to Hillary Clinton's proposed universal health care bill. We all know the Patient Protection Affordable Care Act was pushed by the Heritage Foundation, but they actually weren't the first ones to write it. It was written by United Healthcare, essentially. It was created and it was created specifically to destroy universal health care and as a competitive edge to United Healthcare and versus its competitors. Because essentially, it's in here, but I'll get to that. I was going to go off on a little tangent, but it's actually in here, so I'm just going to go through and get to that point. United Healthcare spent the next 15 years pushing that program with lobbying efforts along with changing structures of United Healthcare so it would be ready whenever the programs would get into place. That's my tangent. Is that essentially United Healthcare wrote this law knowing that it was going to be a law, and essentially they just made it to where they can fall into these rules that they were going to have put into place, so that when it was about to go and be put in place, they could meet the standards when they know their competitors wouldn't. Because healthcare has been planning to meet the Affordable Care Act for 15 years, and the other ones had 2 years to plan. So yeah. So that was kind of the cool idea, apparently. Now, it was easy for United Healthcare to meet these requirements of the plan they created, but of course, the Patient Protection Affordable Care Act was not implemented in the way United Healthcare wanted. The program became detriment to the business. Apparently, that's what they told us, is that because United Healthcare was the biggest proponent, and then I think they only had the exchange plans for 1 year, and then they just canceled the vast majority of exchange plans. Like United Healthcare pulled out of the exchange market in most places, in most parts of the United States. I think New York and a few other regions have it, but that's it. Whereas the first year, I think it was the majority of markets United Healthcare was in, that they just left. Now, yeah, and I go into that. United Healthcare was a part of healthcare exchanges or Compass plans for a year in most of the U.S., and from there they reduced to only a few markets where the exchange plans were marketable. Not once in the 10 years since its passing has the Patient Protection Affordable Care Act been fully funded. United Healthcare would lobby its employees to write their representatives and lobby to keep certain taxes from being implemented. There was supposed to be a tax on small businesses, but it kept being pushed back constantly, and since small businesses make up so much of the U.S.'s workforce, the ACA was hobbled. Additionally, small businesses with 50 to 100 employees were never mandated to provide health care, which was essentially one of the rules. But because the idea, like, what the whole point of the mandate and the whole point of forcing people to get coverage is essentially to have enough healthy people in our system to counteract the unhealthy people like me. Like essentially the drain on the system. And the biggest part of that drain per internal sources was the repeal of pre-existing conditions. And essentially, if there's going to be no more pre-existing conditions, United Healthcare needed to make sure there was some sort of guarantee that they were going to have a lot more healthy people in the system to cover any costs these sicker people would have. Now, of course, most people would be asking, why did the Patient Protection Affordable Care Act require additional funding beyond the expansion of Medicare and Medicaid? And this is where I was kind of mentioning earlier, pre-existing conditions. The only way to get rid of pre-existing conditions was to require the mandate. Now that the mandate has been repealed, pre-existing conditions will make a massive return. Congress just needs to pass a law allowing it. Right now, not having a mandate but requiring insurance to cover pre-existing conditions is speeding us closer to the collapse of the private healthcare industry. Issue is, a collapse will kill millions. We need a stable transition to universal healthcare, or a public option, or some other, government-run plan. In the end, the Patient Protection Affordable Care Act is a failure. All what can be done in 2020 is patch some holes and delay the collapse another 10 years or so. Regardless of what Band-Aid is applied, that collapse is coming. It is always on the horizon, and those private healthcare companies are well aware of it. They just don't care. But early in my United Healthcare career, I actually thought they did, as I was told they did. In the first year at United Healthcare, I was noticing a pattern regarding the plans we were acquiring through acquisitions of other companies and contracted plans with government organizations. 2012 to 2014 seemed like an expansive time for the company, particularly in the public sector. This is when we got several state-run health plans. This is like ERS of Texas, now known as Health Select of Texas, a private healthcare plan for people working for the state of Texas. United Healthcare also obtained TRICARE during this time and had a lot of issues with it. As a quick aside, here we go. TRICARE was insanely mismanaged by United Healthcare that they almost lost it. They were supposed to get over 100 phone reps, but the reps had to pass a background check, but United Healthcare and TRICARE seemed to be fighting over who would be paying for these checks. So by the time these phone reps and pre-certification teams were working on these accounts for U.S. service members, most did not have the prerequisite background checks. By some dumb luck, United Healthcare didn't expose every United States service members PII or PHI to the world, but things were tense. This is what I've heard, and I decided to stick with ERS of Texas at the time because they were trying to get me onto that policy as well. Okay. Going back to my naive belief in United Healthcare's altruistic intentions, I was told early on what UHG's intentions were with UHC and our president, Gale. The reason why United Healthcare was apparently expanding in all these public sector plans, even though the profits were less than the traditional private industry, was because there was a plan to become the Lockheed Martin of private healthcare. The idea at the time was to expand UHC and Optum to get the information of nearly all American citizens into our systems. We would sell link and inject services to the other healthcare companies. Apparently, this was all an attempt for UHG to present UHC as a private, universal healthcare option. Universal healthcare powered by United Healthcare, essentially establish a monopoly and become the U.S.'s private universal healthcare provider, a PMC for health, a PHC, I guess. Of course, this is seen more in the actions of our acquisitions and not spoken outright. What was spoken loudly in the Cinemark Theater was the real conspiracy, the real plan to become the largest private healthcare company in the world. In late summer, kind of early fall of 2012, the CEO of UHG at the time, Stephen Hemsley, had his tour to all the call centers. A lot of us were chosen to go to a Cinemark Theater in West Plano, Texas, near the Cinemark headquarters, off of Dallas North Tollway. And listen to his vision of the future. I had just watched The Daily Show with Jon Stewart the night before, so I was ready to ask a question about diabetes and what we were going to do to stop diabetes from being the death knell of the United States health system. His answer was lacking, just work with partners. And yeah, he was just like, oh, we're going to work with our healthcare partners, the providers, and our partners at Optum Insight, and then I know Optum Insight, OptumRx essentially. I don't think they were called OptumRx at the time, but essentially work with that. What was it? It's called Medcare or something like that. But they're like OptumRx was called something at the time, something else at the time, I think. Now, during his speech, he talked about the future of healthcare for the world. The problem, he said, for a place like Canada, there is no competition. In fact, there are even laws against competition. It was 8 years ago, so I'm obviously paraphrasing, but that was the sentiment. He then explained the plan. They were going to start creating Optum Health centers and place them in Ottawa, Montreal, and London. Now, I can no longer find the Canadian branches, but there was a time where I could find the Ottawa one, and I think a Toronto one, but I can't find them anymore. But the London branch is still located at 5 Merchant Square in Paddington, London. And so the idea is that Optum Health Centers are these lovely places where people could go get health advice and get told how to live healthier lives. A truly altruistic program to help one and all. Out of the same building would be their lobbying arm, the real reason why they're there. For these businesses, they were planning on they were planning on working their way into the government procedures and convincing MPs to remove certain protections and create new rules to allow for competition. The idea is to outcompete the public health plans, and then when the public health plan fails, make the private health plans as expensive as possible while removing as much care as possible. Classic bait and switch under the guise of patient choice. This is spoken as a good thing, a brighter future for the world. I called bullshit right there, but a job's a job, and we have to do what we have to do to put food on the table and have a roof over our heads, and I wasn't going to be homeless again, so I lowered my head and kept working. Throughout my career at UHC, I worked on special projects. My first special project started about call volume, but transformed into pre-existing conditions. We ran reports and had several spreadsheets showing what calls were called in on the most, what claims were called in on the most. Any claim with 3 or more calls were flagged, and we quickly found a pattern. The pattern was that the most costly calls we got were about pre-existing conditions. I can't remember the math for it, but I believe UHC considers every call answered to be cost around $8. Reconsideration costs around $14. Appeals start around $30 and go up from there. It's something around there. It's something around there. That's not the exact numbers that they give us, but it's something like that. Where they consider every single call is a certain amount of money lost. Now, there were thousands of repeat calls, and first call resolution was starting to be talked about, even though FCR wouldn't be a stat for several years. A new standard operating procedure was written due to the special products reviews on UHG's pre-existing condition 6 Sigma pressure points. And the project was saving UHG about $18,000 a month until 1 year after pre-existing conditions were outlawed for most plans. Then it drastically dropped. It still saves the company money because people are still dealing with pre-existing claims even to this day, even though you shouldn't have had to, just sometimes claims live pretty long lives. They're not supposed to. They're supposed to die after like 7 years, but keep fighting them. Now, that $18,000 a month saved is nice, but United Healthcare could have been losing $180,000 a month on repeat calls, and they wouldn't have cared. Pre-existing conditions save UHCs millions of dollars every year. While the talk about pre-existing conditions seems skewed, for example, pregnancy hasn't been a legal pre-existing condition since 1996 for employer group policies, and if you had insurance through one carrier and kept COBRA, or got a new job within the new plan's continuation of coverage date range, all pre-existing coverage would be covered. Additionally, most pre-existing provisions ran out after 1 to 2 years while on the plan. Of course, having pre-existing conditions can affect one's ability to keep a job long enough to pass the pre-X timeline, or find a job fast enough to get continuation of coverage, or have enough money to pay for COBRA. So pre-existing conditions do a lot more harm than intended. There's no valid defense for pre-existing conditions. They are inhumane, but they are required if you can't mandate enough healthy people participate in the marketplace. Which is why private healthcare system is a failure. Working on ERS of Texas, or Health Select of Texas, was probably the best time at the company. Even better than my time working for Prism. ERS, or Health Select of Texas, is a private health insurance company for people who work for the state of Texas. A lot of them are state congressmen, professors at TU or Texas University, or any state college. Just anybody who actually got a paycheck from the state of Texas covered. Let's see here. UHC managed it for a few years before it went back to Blue Cross Blue Shield, after we had a change in leadership with a guy who had a history in venture capital. Before ERS, the employee and individual department didn't really do referrals, and our system was not handled to have referrals anymore. Most people seem to be on the POS Choice Plus or the EPO Choice plans, with the smattering of Select and Select Plus plans, but the vast majority was POS Choice Plus plans or Choice plans. ARS of Texas, and these what they called consumer-driven health plans as well. And consumer is not you. Consumer was your employer. And so your employer-driven health plans, really. And these were the health plans that had the massive, absolutely massive deductibles, ungodly out-of-pockets. The plans that had to be slightly changed when the Patient Protection Affordable Care Act came out. So, let's see here. Okay. ERS of Texas needed referrals. It was how their plan worked. Navigate health plans were created for ERS of Texas, but that's not where they stayed, and eventually Navigate plans became a staple of UHC coverage, and millions were back to requiring a PCP before seeing a specialist, even if they hadn't seen their PCP in years and had been going to the specialist regularly. OBGYNs were really the only exceptions, but there were complications based on if an OBGYN was contracted to PCP or specialist. They're technically both, but for most people, that's not an option. Because when United Healthcare didn't require referrals, then when they would contract OBGYNs, they wouldn't give a shit whether or not they were listing them as a PCP or a specialist. It didn't really matter. It's random. There was no actual rhyme or reason to why sometimes they were listed as PCPs and sometimes they were listed as specialists. Most of the time they were listed as specialists, but because I guess people were just doing the specialist thing. But whenever that came out to be, we now need referrals. Well, even though an OBGYN can be essentially a woman's general practitioner, they can be their primary care doctor. We couldn't assign it to them. We couldn't assign them as a PCP. They had to go get a family medicine doctor or some other GP as their PCP. Even though they don't see that person, they only see their OBGYN on a regular basis. Because contracting wasn't going to talk to these people. There was no way to actually transfer to contracting. You had to send emails, and try to do customer service with an email. The referral system was a nightmare. We really needed to completely re-credential all PCPs and specialists because we needed to re-contract, give them all new contracts. But of course, it wasn't possible. So for those first couple of years on ERS, I and a couple of others became referral specialists. We got access to a system we weren't supposed to have access to, so we could manually add visits and change the rendering provider tax ID number as long as the name stayed the same. The next line is just to let people know that healthcare might want to try to discredit that this was a thing. This is the more part where this sentence means nothing to most people who watch this, but I'm going to say it. TOPS RITA is where this was done. So if anyone wants to say, if one at UNHC wants to say I didn't do this, there, it was TOPS RITA. I used to actually have the rules still until I tossed them away, but yeah. Let's see here. Now, one of our reps had to go on full-on referral master. Even got her own phone line, which is not supposed to be a thing for phone representatives. We're supposed to have just the one phone line that goes through the work at home kit. Goes through the computer into the work at home kit. She, because of all the work she did, she got an actual separate phone line so she can call providers up without having to go through the system to keep calling. Because, of course, outgoing calls look bad. If you have a bunch of outgoing calls, that goes on a report. And so she had to call on a different line, so you weren't doing that. And that's not her job. And she wasn't paid more for that. And that's just how healthcare works. I guess that's really how corporations work. They essentially just make you do the work that's above your pay grade, and they love it. Now, she would actively work with providers to get referrals to work in a way that was well beyond her position. She should have been a provider advocate. Yeah, definitely should have been a provider advocate, but that's like 2 grade levels above where we were at. Maybe even 3. But there's only one line of succession in healthcare for a call rep. And if you knew you weren't going to be a good coach, which she's named for supervisor, then your career begins and ends with a phone, regardless of your skills. The previous sentence is hyperbolic. Obviously, people found ways around it, pre-certification, for example, or credentialing before everyone was laid off and credentialing was sent offshore. ERS was the plan in which our biggest evils got tested. First, referrals, then expanded non-PAR reimbursement program, and then site of service authorizations. Now, ENRP is a big one. It's dry, and we'll have a ton of industry jargon, but I will attempt to kind of go through it. There is a program known as RAPL. Now, it's also known as RAPS, RAPL with RAPL versus RAPLE. It's radiology, anesthesiology, pathology, labs, and emergency program. The idea is that if a patient does the correct thing and goes to an in-network facility, which has out-of-network providers working for it, which most hospitals do, the patient will not be punished. Effectively, the services will be allowed at 100% of bill charges. Now, allowed does not equal paid. When you go into a hospital, you have no option on who walks into your room, who does the testing, which CNRA is going to do prep. It's going to prep you for your anesthesiology. You can obviously be unconscious through all of this and just wake up with a giant bill from many out-of-network doctors, even though you are inside an in-network facility. Now, RAPL with no E, made sure that any bills incurred by these out-of-network providers would be allowed 100% of bill charges. So if your plan coinsurance is 80-20, you'd be responsible for 20% of the entire bill No fee schedule, so the entire bill needed to be paid. No provider write-off is assumed for out-of-network provider. Sorry. I'm going to be doing a little bit of a paint stream. Okay. I don't. Wait. All right. All right. That's where the ENRP came in. The expanded non-par reimbursement program was originally allowed by the Texas Department of Insurance in 2013, from what I understand. This program is actively toxic, and it spread to so many UHC plans since. All right. So here's the insidious way that this works. Normally, RAPL. This is how normally how RAPL works. Let's say that your anesthesiology for an out-of-network anesthesiologist is $1,000. Okay, $1,000. Because of RAPL, RAPS, RAP, or RAPL, that is allowed at 100%, of billed charges. Sorry, okay, kind of hidden something on here. Probably should just remove that. Okay, all right. Let's see here. All right. Now, so $1,000. It's now allowed amount of $1,000. Now your benefits are 80% of eligible expenses. Eligible expenses is just another word for allowed amount, essentially. Now, 80% of $1,000. Oh, I just went here. Sorry, my brain just went off. Is I believe sorry, I'm second guessing myself because I'm on camera now. I did all this mental math and was perfectly fine with it. But yeah, it's like, what was it? It is one. I believe it's 600 or 800, but that's right. Yeah, it's 800. What the fuck am I doing? Like, I don't know. I'm still just gonna be so nervous and just be like, okay, well, let's just do the simple math and just look stupid. So yeah, so I don't know why I did that. Like, it's obviously 800, but I don't know why I'm just second guessing myself. All right, so okay, so that is your plan is going to pay $800. You're going to be responsible for $200 patient responsibility. This is only if we're assuming that coins is paid, out of pocket is not met. Okay, so you still have your wait, co-insurance, co-insurance versus out of pocket, so yeah, no, sorry, not the coins, sorry, no, deductible, your deductible. God, this is such a mess. So deductibles paid, out of pocket's not met. Sorry, it's been almost a year since I worked in healthcare, so some terminology kind of has gotten mixed up. But yeah, deductible is paid, out of pocket's not met. So we're just looking only at the 80-20. Let's just make it as simple as possible. So $200 patient responsibility. Okay. This is how this is how the expanded non-par reimbursement program works. Expanded non-par reimbursement program, anesthesiology is still $1,000, but it uses expanded non-par reimbursement plan uses Medicare rates. Now, based on the plans will pay either 80%. Sorry, there's a little button on this thing. I keep hitting it. 80%, 90%, 100%, or 110. Most plans were 80%. It seemed like the second most used was 100. This was the third most used, and this was the fourth most used, from what I could tell, based on the calls that I got on these employer group policies. Now, let's just say the Medicare rates for this, the Medicare rate, 80% of Medicare rate is $500. So $500 is the Medicare rate. That is 80% of the Medicare rate. Now, any provider will tell you that is incredibly generous. That's not going to be the Medicare rate. Medicare's rates are abysmally low. We're probably looking at more like $200, and then 80% of that would be the allowable amount. But to make things simple, let's just say 80% of the allowable amount from Medicare is $500. So we're looking at $500. So that's $500 that's allowed. This is the only amount that UHC considers. The only amount they consider. All right. It's the only amount the UHC considers. So 80%. 80% of 500 is 400. 400, I don't know why I did percent. That's not. $400. Hey, so what does that leave? That leaves a patient responsibility of $100. Well, then this is how this is kind of thrown out there. Previously, under RAPL, patient responsibility was $200. Under this healthcare program, this expanded non-par reimbursement program, patient is only responsible for $100. Sorry, let me move this over to the side. You can see my silhouette. $100. Here's the issue. This $500, this amount that United Healthcare is not allowed, that doesn't vanish. Out-of-network providers cannot write this off. Out-of-network providers have to balance bill. So the patient's actual responsibility is $500 plus the responsibility that is officially on their EOB. So really, while it may look like we just say United Healthcare just saved the person $100, we actually made them where they had to pay $600. That is expanded non-par reimbursement program right there. Okay. So let me go onto my document. See here, let me go back to full. Okay. That's when so instead of allowing 100% of bill charges, like I said, it would only allow the reasonable customary rates or Medicare rates, both set by the Center for Medicare and Medicaid Services. These rates aren't insanely low, nearly to where providers are taking a loss on anything they do for the patient. This way, this is the way it's marketed now. That's where I went through this whole paint stream to kind of show how the numbers work. How essentially we can say, oh, general anesthesia is $1,000 of bill charges, and then we're going to allow that those bill charges in full at 80%. Patient will be responsible for $200. But with ENRP, our allowable is only $500, and 20% of that is only $100. So we just say the patient $100. But yeah, like the idea is that that's supposed to make sense, right? Like that's good for the patient. That's good for the patient. Except, like I just showed, that's not how it works out. That's not how it works out. See here, the math ignores the out-of-network providers are able to balance bill the patient. When you go to an in-network provider and they charge you $1,000 for a service, and your healthcare has a contracted rate of $500, the provider has to write off that difference and send it to the IRS as a loss, which they get a small percentage back as tax rebates. So technically, our whole system is publicly funded, but oh well. Yeah, that's something that a lot of people don't tell you about. Because these healthcare providers provide, or not healthcare providers, because healthcare insurers provide such low rates for these services, these healthcare providers are relying on tax breaks and tax rebates to make up for the lost revenue that they have for these services. Why? I have internet, don't I? Yeah. Yeah, I have plenty of internet. Okay. Okay. Weird. For some reason, the back end says I have no internet and it failed, and I don't know. That's weird. It says I have 0, but I went to my live page and it says it's running. I can see it running fine, and I have no drop frames, so I don't know. I'm just gonna keep going and hope that the stream works. It looks like it is working still. I'm going to open this up on the front end so I can at least watch myself and see that it actually is still live, which it still is. Okay. I don't know what's going on there, but we'll just push it through. All right. So yeah, let's see here. So yeah, like I was saying before, that weird YouTube thing happened. Our entire healthcare system is already publicly funded in a lot of ways. Specifically in this way. Like I said, United Healthcare, Anthem, essentially any like Medicare rates, even that Medicaid rates, they're all vastly below the actual value of these services that are being rendered. And so these companies, these billing companies, they have to try to make some sort of, they have to get that money somewhere, and so they will essentially write it off, file it with the taxes, and they get a tax rebate back. So effectively, even if you go to an in-network provider, do everything right, that's still partially subsidized by the by the United States government. Private insurance subsidized by the U.S. government. It's like we have public option or and universal healthcare in like the most inefficient way possible. It's insane. So yeah, so like I said, the in-network providers typically write things off. Out-of-network providers have zero requirement to write off the balance, meaning the patient responsible for 100% of the write-off, the amount that United Healthcare did not allow. This ENRP program was not done in order to save patients money. It was done to force these out-of-network providers into joining United Healthcare. It's better for an out-of-network provider to become in-network and take a massive loss than to stay out of network and be unable to get any money from the patients. Because United Healthcare knows most people cannot afford more than a $400 emergency expense, and that's probably already going to a deductible. That may already be going to the physician and the in-network providers, because in-network claims are typically processed faster than out-of-network claims and super bills. So it's really done to punish out-of-network providers. And and the patients are really the victim. The patients are the victim of this like battle that they have no part in. They did what they were supposed to do. They went to an in-network facility. They were admitted by an in-network doctor. They weren't able to push out of-network CRNAs and anesthesiologists. Sometimes in-network providers don't even participate with hospitals. Only out-of-network doctors participate with some hospitals. How? What's the patient supposed to do? Well, per UHC, per these ENRP policies, get fucked. Essentially be used as a weight to force these out-of-network providers to go in-network or suffer a massive loss in the terms of all this debt building up to be balance billed. I do believe ENRP is absolutely evil. It's a decision done to force these actions of providers without actually improving the healthcare of patients and instead gouging other patients for so much more. Like I said, there's going to be providers out there who cannot go in network. And so people who live near these places, these hospitals that have out-of-network providers through no fault of their own, know that they're not going to be paid for the services that they render. And so they're going to get a United Healthcare card. They're going to be like, oh, well, I'm not going to get paid for this. So what does that do to the patient? I mean, it's almost like going in there with no insurance at all. As far as the out-of-network provider is concerned. On top of all this stuff with ENRP, UHC has no requirement to send updates like this out to out-of-network providers. Like ENRP, we didn't tell anybody. Well, I think we sent a letter out to some anesthesiologists. Some of our like the anesthesiologists that like do the service the most. But the vast majority of anesthesiologists had no clue this was coming down the line. No clue. Just as long as the language is on the benefit packet, UHC has done their job. Several larger anesthesiology groups were warned about it in advance, but not enough, and hundreds of thousands of people have been affected adversely by this program that is still being used to this day. ENRP may be why people with health insurance are actually seeing massive bills during coronavirus. I'd probably guarantee it, especially in the early days when we thought it was a respiratory virus and we were getting. I mean, everyone gets a chest X-ray. If that radiologist is not in network, even though you're a network doctor, you're going to be paying much more if you're on a plan that has this program. Okay. And then I jump to site of service authorizations. Health Select of Texas was not the only market that started with site of service authorizations, but of course it was the first rollout in the group. It was one of the ones in the first rollout group. Site of service authorizations are probably even worse than ENRP because of the amount of people it negatively impacts, while also raising the cost of administration on behalf of providers and facilities by a significant portion. Again, it is another program pushed by UHC as a way to save patients money, but any money saved by a patient is actually saving millions of times more for UHC. They tried to argue this was also a medical benefit, as people get sicker if they get certain services performed at a hospital instead of an ambulatory surgical center, and later office when site of service authorization office came out a couple of years later. Actually, maybe in the very next year later. There are several names for pre-certification, but the two major ones I want to point out are prior authorization and pre-notification. The former is a lot more valid. It is more about providing the medical necessity of services to make sure the patient will benefit from the service, and it helps weed out any potential fraud, generally speaking. This is an imperfect system and will be a major headache even under universal healthcare. Pre-notification is more or less a scam. For fully insured policies, maybe it's not. For self-insured policies, definitely so. I mean, like a notification is just like, I'm going to be doing the service. You're just telling your employer group that you're doing the service. Okay, I mean it's covered, so why does it matter? Why does it matter to them? They have a big enough bank for it. I don't know. I know even for fully insured, it doesn't really make much sense. Yeah, pre-certification, I just don't see it as being a valid thing. And the pre-notification, pre-certification programs are just used to trip up UHC providers so that the company UHC can have an excuse not to pay for certain claims or pay with a massive penalty, lowering the cost to UHC dramatically. The vast majority, something that could be argued as virtually 100% of site of service authorizations, are all pre-notification. Site of service started out with several codes, but the biggest hit were 45378, 45385, 45380, and 43235, and 43239. These were kind of colonoscopy and endoscopy CPT codes, kind of the more popular ones. These services didn't require prior authorization on most plans for decades before the change. There were a lot of warnings sent to in-network providers for this change, but it still had a major negative impact on thousands of providers. This is an out-of-date link, but I can still show it. I think this is last year. Yeah, effective September 1st, 2020. I mean, in here, like we'll go down here to the site of service. Let's see, all the way in the S's. I guess I could just go searched site of service. A lot of these are diagnosis codes as well. Oh, CBT codes, but the massive lists are more. Okay. So, site of service, office-based program, site of service, outpatient hospital, and just look at all these codes, all these services, all these services. This is still continued. All these services. We're still going. We're still going. Oh, and look, expansion. Phase 2. So even more codes were put through. Like, this is almost like every single out-of-network outpatient procedure requires certification with, or the site of service authorization with United Healthcare. It's insane. And when you do that many authorization requirements, I mean, it explodes the amount of, it just literally just explodes the amount of administrative costs you would have normally. Now, you may have seen that says prior authorization is not required for care providers in Alaska, Kentucky, Massachusetts, Rhode Island, Texas, Utah, and Wisconsin. That used to not be the case. So, glad that several states fought back on this and actually don't require it, or put laws in place to not require it. They're not allowing this to be required. New York used to be an exception. It's no longer an exception. So I don't know what's going on with New York. Now, the idea behind site of service is that patients were being sent to outpatient hospitals for simple services too often. I mean, that's kind of your opinion, man. When that's just healthcare bitching about having to pay out. That a colonoscopy could be done at an ambulatory surgical center, and if the provider wants to perform the colonoscopy at an outpatient facility, then they must notify UHC, or the claim will be denied or paid at a massively reduced rate. Issue is, tons of providers are not privileged at an ambulatory surgical center and will never be privileged. On top of that, there are huge parts of the United States where an ambulatory surgical center does not exist. Doesn't matter. Those are let's see here. I think I'm put something wrong. It doesn't matter though. There are exceptions to get a notification approved faster, but does not remove the requirement altogether. I mean, it was essentially like email pre-certification at uhc.com, or it was some very just basic email that we had to use. A sore spot, a huge sore spot, was Cleveland Medical Center. Now this happened after I left ERS of Texas for the Platinum Provider Service Model, PPSM. A department focused on working with our highest rated and most efficient providers. Cleveland Medical Center is a teaching hospital, and a massive one of that. Now, what could possibly be the issue with a teaching hospital being required to have notifications for simple services like these? UHC can't credential students. Kind of a big deal. When we try to submit an authorization and go, they have the doctor's information. They're not a doctor, they're a student, but their name is this. They have a tax ID number? No. Do they have a social security number? I don't have that. All right, well, I can't submit authorization. Now, of course, we were given the ability to manually put in these providers, but the issue is all those claims would then go to a person to review and they would deny it, saying, oh, we don't do authorizations for out-of-network providers for site of service. But the thing is, Cleveland Medical Center was in-network, and all their doctors, students or not, are to be paid in-network as well. But the system was not made that way. So yeah, when we would ask, who's the renting provider? Oh, well, they wouldn't come up, so it'd add them as out-of-network, manually entered provider, and notate, provider's a student, facility and referring provider are in-network, do not provide adverse determination for incorrect out-of-network status listed. And wouldn't you know, a ton of those were denied for rendering provider out-of-network. So the pre-cert team at Cleveland Medical Center tried to give us other doctors' informations, like the attending on staff, referring doctor. This is not correct, and this whole situation got so bad that Cleveland Medical Center, which is not just a single system, but a giant group that helps most of that city, it seems, was about to leave UHC. They were just not going to stay in network. They were going to leave our network. Eventually, UHC gave them a contract that stated that they would be exempt from SOS going forward. That's how terrible site of service was implemented. And Cleveland Medical Center is not the only teaching hospital to go through this, but most teaching hospitals are managed differently, and if Baylor isn't complaining, nobody really seems to notice at UHC. No, hold on. Okay. Cleveland Medical Center is not listed on this right here. Now there may be like the front end of UHCprovider.com does hide a lot of stuff like that, so most likely that is still on the internal list. I'm pretty sure Cleveland Medical Center still does at this point does not require site of service authorizations, but I of course I can't make that determination myself. I'm just saying that based on the history of healthcare. So hopefully that still all worked out because they were about to leave, and that affected millions of people in the state of in Cleveland really. But I mean, like I said, they're all over Ohio, so it would have affected a lot of people in Ohio. Let's see here. Okay, almost done. UHC does not save privileged status. Let's see here. Okay. UHC does not save the privileged status of these providers. The provider can call in 200 times a month for the site of service authorizations, and UHC will never figure out that this person will never have privileges. And all what will happen to these providers is that their administration costs rose. All what happened for these providers is that their administrative costs rose. There's literally there's no way. There's no part of a contract or any thing that credentialing can click that says this provider cannot ever be credentialed at an ambulatory surgical center. So no matter what, every time they call, they know they get you in healthcare. They're like, do you require authorization for these codes? May I have the codes, please? 453, 78, 45380, 44385. President's policy. I showed that they're primary. Healthcare is primary. So yes, authorization will be required for these codes, unless done at an ambulatory surgical center. Okay. Like, the administrative costs rose for UHC as well, which is why early on I was expecting SOS to be abandoned altogether. But no, it was only expanded, and as you saw earlier, it's massive, and they're already working on a phase 2 to expand it even further. So now you'll need pre-certification if you wanted the services performed in an ambulatory surgical center instead of an office. That was the office expansion program. Early at United Healthcare, I was given a figure. This figure is massively out of date now. But back in 2012, I was told that the United States of America pays $3.5 trillion for $3.2 trillion worth of care. Now, I think that number is skewed because I was also told that administrative costs account for 70% of waste in the healthcare industry. The biggest part of waste? Claims. Claims are an absolute nightmare to go through. At United Healthcare, I love claims. I preferred claims over notifications and benefits. Claims are where I thrived. I actually enjoyed reading certain reimbursement policies. The way to navigate through billing was fascinating to me. And I loved finding some provision or rule I could use it to justify for me sending a claim back to get paid. My document kind of ends there. So let's just kind of close that out. So that's not really everything. That's kind of like the boilerplate kind of stuff I've kind of ran into and frustrations I've had with the healthcare system. This document misses out a very key thing, though. Back in February of 2019, we had a state of the company meeting. In this meeting, we talked about our NPS provider scores and all the standard boilerplate corporate talk about how we're improving as a company. But at the end of this conversation, the heads of United Healthcare, not the president, of course, but a lot of upper management, they were like, they kind of came to a point where they're like, okay, well, before we gotta get there, this was also the meeting where they're like, oh, we're not gonna lay anybody off. We're a healthy company. We're one of the biggest healthcare providers in the world. We're more profitable than ever. They were laying people off before and after and during. But at the end of this conversation, or this town hall, they called it, they ended the call saying the average American is growing unhealthier by the day. They're growing sicker and more unhealthier day by day, year by year. And there's going to be a point where United States citizens are going to be so unhealthy that the healthcare system will collapse. So, if you have any innovative ideas on how to resolve this issue, please send us an email through Frontier, the website, the employee website. Cool. Of course, the real answer is to get universal health care, but they don't listen to that. And actually, later down the year, they did a second town hall actually on Halloween 2019. So I get to see Batman and Jeff Gordon talking about how Bernie Sanders is wrong about universal health care. It's a surreal world we live in. Uh, yeah, yeah. They know. They know. United Healthcare, most people know that this is unsustainable. They don't care. I mean, maybe they care in some way, but they don't care enough to realize that their um, industry is the problem and that we need universal health.